Hello everyone, welcome to the GI module. This is the first lecture we have. Pretty big PowerPoint presentation, you guys probably already noticed, so I will be doing a part 1 and 2 at least, maybe a part 3. I think I'm just going to kind of chop it in half, but we'll see how it goes. So definitely make sure you listen to all parts of this lecture to get the full picture. This is a jam-packed lecture. There's a lot of stuff going on in this PowerPoint presentation, make sure you study that and focus on that. This is one of 2 bigger presentations for this module, and then there's some smaller ones. But then, like I said, this one has a lot going on, so make sure you pay attention to this, study this. First off, just some of the disorders we're going to be talking about. You'll be getting more of these in ICM and pathophysiology courses, but just to make sure everyone's on the same page, here's some things that we are going to be covering here. Or rather, we're going to be covering some medications that treat these diseases. So just go ahead and read through those. And then this is a slide that's important for mechanism of action later on. So these are some of the neurotransmitters that are going to be involved later. You will see with mechanism of action. So this is just kind of an FYI slide, but we will be seeing these again and definitely need to make sure you pay attention to these things, specifically histamine, for example, when we talk about mechanism of action. Also related to mechanism of action, this is a great slide, especially for you visual learners out there. I like it a lot. It helps me memorize mechanism of actions. You'll notice the drugs are listed here in this orangish color. Hopefully the color's showing up okay on you guys' screen. Orangish color, and it's showing where there's a blockade. So for example, I mentioned histamine, for example. We have H2 blockers. You'll remember from previous lectures, we had the antihistamines. Well, those were H1 blockers. So they were antihistamines. These are a little bit different because of where these histamine receptors are located throughout your body. And like I said, you'll be going through that in detail in pathophysiology, where the H1 receptors are located and H2 receptors are located. But specifically for the GI module, you have H2 receptors throughout your GI tract. So this is where you get the H2 blockers. So we're going to talk about these medications more in detail here, but that's just an example of how this slide can help you for studying purposes, because this may help you give kind of a visual representation. H2 blockers, what are they doing? They're actually blocking the H2 receptor in the GI system. So also here we're going to, this is the ATPase. You'll notice here it's a pump. This is a proton pump, because here's H+, which is a proton. Remember back from biochemistry, undergrad. And these are the proton pump inhibitors. And those actually are not in orange. So I know I said orange earlier, but so these 2 are drugs as well, Misoprostol and omeprazole. But then, yeah, so kind of inconsistency here on the part of the book here. But so orange, and then this is also a drug here. So, and like I said, we'll be seeing this slide a lot, and I think it's good reference and a good one to refer back to. First, we're going to talk about drugs that decrease the gastric acidity. So a number of different reasons why you'd want to do that. Go back to that first slide and see some of the pathological disease processes that can be happening where you'd want to do that. Most common and what most people think of is GERD or heartburn in lay public, or so acid reflux is another one. Common ailment that a lot of your patients, outpatient setting and inpatient setting, you'll have to be thinking about and dealing with. So you will see these medications, these H2 blockers, proton pump inhibitors, and these antacids used in a variety of different settings. Definitely see it in the hospital, outside the hospital, because for better or for worse, acid reflux is an issue. And you guys maybe remember from some other presentations, sometimes medications can cause acid reflux or cause GERD or GERD-like symptoms. So, again, something too, that if a person's on a lot of medications, they may need to be on one of these medications that decrease gastric acidity. So yeah, you see them a lot. And then again, over-the-counter, these are over-the-counter medications, and some of them are, and then some of them are also prescription or prescription only. First off, we have the H2 blocker, so histamine 2 receptor antagonists. This is going to be, I think, more straightforward for you guys, because for categorization purposes and mechanism of action, you can think of it the exact same thing. Think of it, you can categorize it H2 blocker, and then for testing purposes, as far as mechanism of action is concerned, you can, I'll refer to it as an H2 blocker, an antihistamine. I will be specific though. So in the past, there have been times when I just am sort of generically saying antihistamine. This is something that you do need to pay attention to the subtype of the receptor. So it's an H subtype 2 receptor because those are found primarily with the in the GI system. And so, you know, H1, H2, this is something you're going to need to start paying attention to and start memorizing and keep that categorization similar. So you have them all listed here. They're all pretty similar. These are all generic names. Like I said, over the counter, these are available over the counter too. Similar ending in them, so that students in the past have said these are probably a little bit easier to remember just because of the similar ending. They're all pretty much created equal with the exception of cimetidine. We'll get into the details of that a little bit. Mechanism of action here. I have cimetidine on the top here, but this mechanism of action can be used for all of these H2 blockers. So I've had students in the past, and apologies if this is unclear, but they were like, well, you said this was just cimetidine and it's a little bit different, but mechanism of action for all the H2 blockers, you know, you can use this slide for that. Take home point, they block the H2 receptor. And then what does that do? That lowers gastric acid secretion. So take home point there. But you definitely read through it. Refer back to that visual guide, that slide we had here. Here we go. Here with the H2 to maybe kind of give you a visual representation. But again, gastric acid take home point is going to be reduced. They are pretty effective. I'm not going to say that they're the most effective. You'll notice that it is kind of upstream, so to speak, of the gastric acid production. So if you look at the cascade here, you'll notice that acetylcholine, gastrin, they can still have their effects, and prostaglandins here can still have their effects. PGs, prostaglandin. So you know, they work and they're helpful. But as far as we're going to get into the other ones, specifically the proton pump inhibitors, they're a little less effective. But you know, it's still great medications. You see them prescribed a lot, see them used a lot, like I said, over the counter and prescription. Cimetidine. So we have some uses here for this one. Again, these uses can be used for the other H2 blockers. This adverse effects, however, are going to be a little bit different. Cimetidine is one that is not as well tolerated as the other H2 blockers. So that's why I did the slides a little bit different. So when you're studying it, hopefully the take home point is that, you know, cimetidine is an H2 blocker, but it's not as popular. Just because the adverse effects, it's usually not as well tolerated, specifically with endocrine and metabolic. So gynecomastia is an issue. Could happen up to, I put the percentages here, you know, it can happen there. You know, so it is not preferred because of that. The other reason to put a star here, cimetidine does have a problem with the drug interactions. So it's unique of the H2 blockers. This one does go through the P450 system, which we've seen before. And so you do have to put a star here, and remember, you know, I want you guys to remember cimetidine. And anytime you think of cimetidine, it's like, you know, phenytoin, warfarin, whatever. We have this list we've been building on all year, and think of drug interactions. So because of that, and you'll notice a lot of common medications, beta blockers, benzodiazepine, calcium channel blockers. So it is of the H2 blockers, again, the least popular. So what you will be probably prescribing and seeing on the formularies in the hospital, etc., are the other H2 blockers or H2 receptor antagonists. Ranitidine is a popular one, famotidine, and nizatidine. Sorry, I got to slow down to say that one a little bit. Again, mechanism of action is going to be the same as cimetidine. Therapeutic effects are the same. The uses are the same. However, the big advantage of these is overall less adverse effects to be concerned with, and you do not need to worry about the drug interactions like you do with cimetidine. So another huge advantage, right? It's always nice when you're prescribing medications to not have to be worried about drug interactions. Then these are also more potent than the cimetidine. So the cimetidine is the older one. It is it's the father or grandfather, whatever. I don't know how many, father, I guess, not the grandfather, of these H2 blockers. And so they, you know, and you see this a lot in drug design. They'll start out with one kind of parent compound, they call it, and then it has drug interactions, it has adverse effects, and then they'll refine it. The medicinal chemists, right, organic chemistry, you guys remember that? They'll go and they'll tweak the chemical, they'll chop off a methyl group, they'll add an OH or hydroxyl, whatever. They'll do all this fun, fancy chemistry stuff, and they'll make it a better medication. So they'll maybe make it where it doesn't have as many drug interactions, less adverse effects, etc. So this is a story where the H2 blockers, they kind of follow that story too. So for prescribing purposes, for testing purposes, I want you to know all four. So learn all four, categorize them all as H2. But for prescribing purposes, purposes as far as your rotations and for your out in practice, I want you to know the rationale as to why to pick these over the other ones. So yeah, have students in the past say, hey, Dr. Strong, Cimetidine so horrible. We can just forget about it, right? We don't need to study it. No, please still study it. It's still around. You may still see it every once in a while. I don't know. But yeah, don't completely, get rid of it. Its uses, we have all the uses that we mentioned before, cimetidine plus H. pylori, so Helicobacter pylori. It's given in a cocktail, a combination of things. These H2 blockers are one of the cocktail or one of the combinations of things. Stay tuned. We're going to get into the H. pylori treatment here in a few slides. I have we'll get more into it. And so, but just know that H2 blockers are part of it. Rare but serious adverse effect, thrombocytopenia. So just put a star by that one. That's not a common one you have to be concerned with, but again, rare but serious. So I want to make sure you guys know when those are an issue. Going on now to the PPIs, which are the proton pump inhibitors, very popular drugs. Some people jokingly call them vitamin P. You'll hear that sometimes in the hospital. They used to say it on my rotations and stuff. And it really, as a nervous, stressed out pharmacy student, I was freaking out because I was like, vitamin P, what is that? I have never heard of this. I don't remember that from any of my classes. And then the pharmacist like, calm down. We're talking about proton pump inhibitors. So I took a breath. I wiped the sweat off my forehead. And I was like, oh, proton pump inhibitors. I remember those. So yeah, sometimes people, I don't know. People have stupid nicknames for things. And but anyways, these are very popular. Like I said, they're also very potent. They are very effective. We'll go back to that. I don't know where we have that other slide. So here's the slide just real quick. They are downstream, so to speak. They are that rate limiting step. You guys remember that from biochemistry. Rate limiting step here. They knock out this proton pump. They block that. So very, very effective. And they permanently disable this proton pump, which is interesting that they, permanently do that. And so I've had students in the past say, well, then they permanently reduce, knock out gastrin production, or, they permanently will then get rid of your acid problem. Theoretically, and that makes sense. I get the logic, and I definitely understand why students are thinking that. However, your body, and you'll probably learn this in pathophysiology, naturally regenerates these pumps. And so it permanently, the drug will permanently knock out this pump, but your body, grows a new pump essentially. And so you won't forever have, no acid production, or but for that one pump, that one proton pump that it does inhibit, it is a permanent inhibition. You'll notice too, these are probably pretty easy to remember, and I'm not supposed to say easy, I'm sorry, but pretty straightforward to memorize, because they all end in they all have the same ending. And you'll notice too that, common sound alike, look alike error that people will make. These are not related to the azole antifungal medication, so please keep them straight. Please keep the spelling straight. I've had students in the past say, I've been tricky with some of my answer choices and some of the things I spell. So yeah, I do misspell things, and I'm sorry for doing that, but that's getting less and less, right? But so please pay attention to spelling. I will sometimes be kind of tricky or whatever, and I'll throw in and make sure you guys aren't picking an antifungal medication. So please pay attention to the spelling on these. It is important you're writing the correct medication when you're sending me prescriptions in the pharmacy, right? You can't be like, oh, something with an azole at the end of it, right? And it's for then I'll be like, is it for fungal infection, or is it for their GERD, or do they have a stomach ulcer or something, but anyway, so please pay attention to spelling on that. There's been some students who've have confessed afterwards that, oh, I didn't think I was gonna have to really know them all. Yeah, no, yes, please know them all. It is a real thing. Another thing I think will be helpful with studying this is, again, for classification purposes, I will classify them as PPIs, proton pump inhibitors, for testing purposes. And then also for mechanism of action, which is our next slide here, I will also that's the take-home point for mechanism of action. So it's kind of a 2-for-1. I think that usually helps. I'm not going to say always, but it usually helps students for studying purposes. I always appreciated that when I was a student. I was like, yay, it's the same. So it's classified the way the mechanism of action is. But here is all the, the detailed nuts and bolts of it. But take-home point, it's going to block that proton pump. But read through this. It's got some good stuff. And then what does that do? So less protons. You guys remember protons will hopefully from undergrad cause a more acidic environment. So by inhibiting those protons from going out to the stomach, you therefore lower the acidity. So that's the reason why we're interested in these and why we like them and why they're prescribed at time. This is interesting too. They are, and this is more kind of an FYI, but it's just, I think it's interesting and it comes up sometimes, but it may be relevant later on in your practice or not. These are prodrugs. So you guys remember that is something it's chemically modified in a certain way to kind of pass certain environments to then get to where it's going to be its active drug later on. So it actually does require an acidic environment to be activated. These drugs need to be able to pass the acidic environment of the stomach to go to the small intestine, where they're then absorbed, and then they go back and block the proton pumps. And so that's where the drug design kind of comes in here. And then you can just look here. These are the two that aren't in orange for some reason. They're in black there. And then mechanism of action here. So, just a little bit more details and just a little bit better said, I guess, than the way I just said it. But basically, they need to make, the take-home point of this slide is that these medications, they have enteric coating. It's also known, I don't know if I've talked about this yet with you guys, but it's also in lay public, or some people refer to it as a candy coating. It's not candy. It's not delicious. It's not just sugar, but enteric coating is basically a specially formulated coating over a medication. So you'll see this with there's enteric coated aspirin. These are enteric coated. It's just basically anytime you want something to be protected, for the environment you're putting it into, I guess, in most general terms, but specifically with the enteric coating here, the coating is supposed to protect the medication to pass the very harsh and hostile environment, the low pH, the very acidic environment of the stomach. So this is all that this is saying. So this is more FYI. I've had students in the past, oh, do you want me to memorize this? And no, it's just, it's more of an FYI. I think it's interesting too. I guess it's something in pharmacy school we would spend a lot of time on, drug design. It's just something I just thought was kind of cool. But it's kind of related to mechanism of action stuff. But take home point, mechanism of action, proton pump inhibition, right? These are great drugs too, like I said, and specifically they actually help promote the peptic ulcer healing, and then they help prevent that ulcer recurrence. So more effective than other medications, like I mentioned, the H2 medications. So they will be superior to those H2 blockers. Oh, and one thing I forgot to mention too, and I guess I'll go and let me jump back for a second. Jump back here to the H2 blockers. Just one other thing about its use that I forgot to mention, but in that other slide kind of reminded me that you will see these sometimes being used with allergic reactions. So we have histamine blockers all over the place, and typically you think of, and there's the H1 and the H2, right? And you typically think of with an anaphylactic reaction or with an allergic reaction, you typically think of giving Benadryl, right? A first generation antihistamine H1 blocker, diphenhydramine is the generic name, and you think of that because it helps reduce hives, it helps reduce the redness, swelling, itchiness, etc., which is it's good. But you'll notice in an inpatient setting, and it depends on the facility you're at, depends on the physicians you're going to be working with and everything. But it's happened enough where I feel like it's noteworthy to notice noteworthy for students rather, is that you will see when a person is having a severe allergic reaction in a hospital setting, they will go ahead and give them an H1 blocker, so like diphenhydramine, let's say, and an H2 blocker, so like ranitidine, let's say. So they basically will give them all H2 blockades. They just want to hit all of, because they have been found to be somewhat effective. It's not considered, first line or what you go to. So if someone has hives or something, you don't say, oh, here, have some ranitidine, an H2 blocker. You typically go with, an H1 blocker, first generation antihistamine maybe, or second generation H1 blocker, antihistamine. But in patient setting, they usually, it's kind of like that saying of just throw everything at them, but the kitchen sink or something. I forget the saying. I don't remember what the saying is. Something about throwing a kitchen sink or something. I don't know. Email me that if you guys know the saying, but no big deal either way. Something about throwing this, but it's just one of those strategies where, it's a severe enough reaction. And my wife just recently, there was someone when she was on call, and she gave H1, H2, and epinephrine maybe. It's just you kind of you give everything at your disposal, because it's not going to hurt anything, and there is some kind of small benefit. And again, there are these H2 receptors all over the body. Primarily it's for the GI, and that's its primary use, but it's all over, and it has been shown to be effective for those. So kind of it's like an off-label, kind of a niche use, but just heads up, you may be seeing that at your different hospitals depending on their formularies and protocols and stuff. So getting back to here, just take home point, these PPIs are good, and they're actually advantageous over the H2s because they help actually, the ulcers actually heal, and then they are better for GERD and for peptic ulcers. Uses, notice all the uses here. Definitely pay attention to this. Want you guys to know this. And like I said, you'll be seeing these in a lot of different settings, inpatient and outpatient. Like I joked too, they said, oh, it's vitamin P. Everyone gets it at the hospital. So yeah, you'll see, it's pretty standard on, protocols and stuff and in the hospital, even if a person doesn't have a history of GERD, or they have a history of just being in that stressful environment, and then because they're hospitalized and maybe their diet isn't great, or they're on a lot of different drugs. So unfortunately, like I mentioned before, a lot of drugs have GI adverse effects. You've hopefully noticed that trend throughout this last semester and this semester, hopefully noticing that trend. When I talk about common adverse effects, a lot of them, it's like headache, GI, right? So a lot of drugs, unfortunately, can cause a headache, and a lot of drugs, unfortunately, cause GI adverse effects. So this is part of the reason why you see these proton pump inhibitors prescribed a lot. And like I said, in an inpatient setting too, patients on a lot of medications they're not used to being. So they just go ahead and put it in there because, and maybe they're laying down too. There's another reason too. So gravity, you'll learn in pathophysiology and in maybe an ICM too. So gravity is also an issue with some of this acid reflux and with GERD. So maybe the person isn't able to sit up, walk around, do the normal activities because they're hospitalized, right? So they're in a bed, they're laying down, maybe if it's even at an incline still. So yeah, I see these a lot, take home point. So please pay attention to the uses. You also notice too that it is part of that drug cocktail that we're going to talk about more in detail, but for H. pylori. Stay tuned for that. Last category we have here are the antacids. So these you guys might be familiar with. Like me, when my grandma always had these in her purse. I don't know. Grandmas and aunties always have these in their purse. No, that's a stereotype. No. But yeah, so these are things that they're over the counter. It's like Tums, for example. And these basically are weak bases. So again, shout out back to biochem, undergrad biology, chemistry, whatever. So you have an acidic environment, highly acidic. One way to help neutralize or to increase the pH is by adding a weak base, right? So these are all basically weak bases. Sodium bicarbonate, aluminum hydroxide, magnesium hydroxide, calcium carbonate. Mechanism of action. Okay, so depending on what textbook you look at and what sources you look at, you will get slightly different mechanisms of actions for these. But for testing purposes and for my course, take home point here, mechanism of action, basically neutralize, or they help neutralize rather, the gastric pH. So they help increase pH, right? So they help make the acidic pH of the stomach increase in number. So what does that do? It makes it more basic, right? So take home point is that these are weak bases. So again, it's not as clear cut and not as nicely packaged as the proton pump inhibitors as far as categorization. But so categorize these as antacids, think of them as weak bases, and then that will hopefully help you with the mechanism of action. Because you have an acidic environment, you want to make it more basic. So this is what these are doing. So these are used for symptomatic relief. So again, these aren't great, or rather they're not as good as the PPIs. So far what we've talked about, and I'll go back here on this slide. So of these, usually first line, most effective is going to be your proton pump inhibitor. If you're interested in decreasing gastric acidity, kind of the most effective tool in your toolbox, so to speak, is going to be your PPIs. Then your H2s. And again, this is all patient specific, right? So, warning on the exam, depending on the patient's vignette, depending on that specific patient, are they old? Are they young? Are you concerned about drug interactions? Are you not? Are they allergic to a medication? Are they not? Right. But just, general average patient, proton pump inhibitors first, H2 blockers second, antacids third. Unless it's, again, patient preference sometimes too. So I know that, especially in the pharmacy, they have these H2 blockers over the counter. They have the PPIs over the counter now too. Antacids are over the counter historically. Like I kind of joked with my grandma, her generations, they would go grab a Tums, so to speak. And they had those. So patient preference too, but I mean, as far as them being effective, the antacids are not as effective. They do help symptomatically, but they, unfortunately, especially if you use them regularly, they do have some adverse effects you have to be concerned with. First off the bat, I'm going to jump back here. You have to be concerned about electrolytes. So you notice this has sodium in it, this has aluminum in it, this has magnesium, this has calcium in it. So again, can be bad or good depending on the patient. You can get into trouble with some of these medications because of the cations in them, right? Because for example, this has sodium in it, so that can be problematic for the patient. Symptomatic relief, though, kind of going back to that too, they should be used PRN or as needed, so you don't get it. You typically don't have as much of an issue with these adverse effects. I'm hesitating again too in my voice. Hopefully, you can hear my hesitancy because again, you know, these are available over the counter. So unfortunately, these patients may be coming to you where they have been taking these antacids at higher doses around the clock. And it says on the bottles, I don't know if you guys have ever read it, you know, the bottles of these antacids that are over the counter, they say, you know, only used for a couple days and then contact your healthcare provider or whatever, which is you guys, right? Future PAs of, but you know, and it's not always, that's best case scenario. So, you know, you also see people just kind of like sipping on these bottles of these antacids over the counter and stuff. It's like, you know, all day. But yeah, so the adverse effects specifically, so diarrhea with magnesium, constipation, aluminum and calcium products, or you know, products that contain aluminum and calcium. The magnesium too, we'll note here a little bit later on, this can be actually advantageous if a person is constipated. But again, there's some niche uses for that, and we'll talk about it a little bit later. Constipation, again, depends on the patient. Can that be an issue? Systemic alkalosis, right? So we talked about that specifically, what, you know, who your patient population is. Are they elderly? Are they not? They have impaired renal function, right? So like you guys have hopefully already noticed, talk a lot about the kidneys in this course and a lot about the liver, but specifically here, we need to be concerned with renal function. The other thing too with sodium bicarbs, this is can actually cause reflex hyperacidity. So what does that mean? It actually can make the it actually tricks the body, or it causes the body to produce even more acid, and then it makes the environment more acidic. So it can actually make your symptoms worse and make the issue worse. And specifically for PUD, or peptic ulcer disease, it can make that disease worse, and it's contraindicated there. Also note too that for elderly, they should stay away from it because of the sodium content. And again, you can have issues with systemic alkalosis. And then also too, that generalization, hopefully you guys are, excuse me, that generalization you guys are hopefully making now. Elderly person typically means, you know, decreased renal function or decreased decreased renal function, right? Elderly person, you know, typically equals decreased renal function. So that can be another issue too, and related to the systemic alkalosis. Cytoprotective agents. So changing gears here, these are basically like to think of, well, it's in the name. So cyto means cell, and then protective means, you know, it protects. So these will help protect the cells. And so these actually bind. These are sticky molecules, if you want to think about that. They bind to ulcers, and they help protect the ulcer against that harsh acidic environment. So first we have the sucralfate, which is the chemical name here, aluminum sucrose sucralfate. For testing purposes, you just sucralfate is fine. The kinetics here, I normally don't make you guys memorize those or work about those, but I do. In this instance, it is important because this is actually, and it's related to the kinetics, is poorly soluble. So it actually polymerizes, which means forms little chains and like a net-like structure in the acidic environment. So you don't get absorption. You have no systemic effects. You don't have to really worry about, you know, absorption and then adverse effects and organ damage, etc. So it basically kind of forms a coating that polymerization via polymerization. So it forms a little net-like structure and actually covers it up. So you notice here, and it's actually designed to specifically bind to that necrotic ulcer tissue, which is pretty cool. And then, like I said, it's like a blanket. It's a barrier, right? So then it helps that the ulcer heal. It also helps stimulate prostaglandins, which I know you guys had in pathophysiology last semester, way back when, and no one remembers. But basically, what do? Those help. Those have cytoprotective effects as well, and those help with the help the cell and the ulcers heal. So they have a beneficial effect as well. So it's kind of a twofold there too. Excuse me. Uses, probably pretty clear by now, because based on the mechanism of action, it helps treat the active PUD, and then it helps to suppress the recurrence. It is typically a short-term treatment, though. It's not typically used long-term or greater than 8 weeks. Misoprostol. So this is an interesting one. This is actually a prostaglandin analog, prostaglandin E1 subtype 1. So this inhibits the secretion of gastrin, also promotes secretion of mucus and bicarbonate. So it does all of those things to help aid in the healing of the ulcer. Another interesting thing too, specifically for NSAID-induced ulcers, it helps replace the protective prostaglandins that are depleted by the NSAID. So because of that, its use makes sense. It helps prevention of NSAID and steroid-induced gastric ulcers. It's also going to be used, and we'll see it in the OB-GYN module. I'll talk about more there. It can be used for the medical termination of pregnancy. And then it has some unlabeled uses here, which are related to what we're talking about in the OB-GYN module, but then also NSAID-induced nephropathy. Adverse effects, usually GI adverse effects, like I said, with most drugs. Vaginal bleeding as well. For women, you have to be concerned with that. Contraindication, definitely put a star by there. Want you guys to know. It kind of makes sense too, or if you think about with the medical termination, it is contraindicated in pregnancy. So definitely put a star by that. Want you guys to know about that. Even though it's not the OB-GYN module, still put a star by it. Want you guys to know about it. And then here is the entire boxed warning on it. So it is contraindicated. They do have a box warning on it. Go ahead and read through this. It's important, but take home point, contraindicated, FDA box warning, that shouldn't be used in pregnant women. And then it should be used in caution with women of childbearing potential. So having said that, this isn't a super popular drug. I mean, it's got its niche uses. You'll probably see it being prescribed more by the specialist, the GI specialist, and probably not be seen by your general practitioners and stuff. So depending on where you're working and stuff, you may or may not see this one, but definitely for testing purposes, put a star by this slide as well. Then we also have the colloidal bismuth compounds. So this is a bigger category, kind of a catch-all. The big one in this category that most people think of is Pepto-Bismol, or bismuth subsalicylate. This is that pink stuff over the counter I think everyone's familiar with and has seen before and maybe used. This is another one too that has a, selectively binds to the ulcer coating, and then it helps protect the ulcer. So again, it's kind of that blanket. I keep using blanket. For whatever reason, I think of a blanket over an ulcer with all these drugs. Whatever visualization helps you guys, whatever. It has some other uses though, and related to GI, it can help with treat diarrhea. Specifically traveler's diarrhea. You will see this, again, board questions, and it's the classic person goes overseas or leaves the country, they get diarrhea, whatever. So they'll usually they make these in chewable tablets. So they'll recommend, if one of your patients is going out of the country, take some of these chewable bismuth subsalicylate, and then they can have that to help them with their traveler's diarrhea. It also helps with heartburn and dyspepsia. So again, popular over-the-counter medication. Also be used in combination with H. pylori. So we'll talk about that. Again, part of that cocktail. We've already talked about the H2 blockers, PPIs. This is the third, and there's a couple other things. Adverse effects, usually well tolerated, other than it can darken the stool and darken the tongue, and it freaks people out. So definitely one of those common ones, but it's pretty benign. It's not anything to really be scared of, but it does, like I said, freaks people out anytime they have a black stool or their tongue turns black. So that's something definitely to think about and warn your patients about. Other thing too, go ahead and please add. You'll remember from previous modules we talked about Rise syndrome with with aspirin or aspirin-like compounds. So the subsalicylate is chemically related to aspirin, and close enough so that you do, so go ahead and add this on the slide, put a star by it, that you do need to be cautioned, and this should not be used in pediatric patients under 12 years old. So again, important to remember, it's over the counter. Unfortunately, you see, we try to catch it in the pharmacy. If we see anyone buying it for their kid or whatever, we tell them it's not recommended for children under 12 years old. And again, that's because of the risk of Rise syndrome with aspirin or aspirin-like containing products. So or it's salicylates specifically. So anything with salicylates in it should not be used under patients with 12 years old. So I've been talking about this whole time, H. pylori. So H. pylori is a bacterial infection that was interesting history, and it was basically the scientist, and I think it was in Australia or New Zealand, somewhere down under. I think, don't quote me on that. That's not going to be on the test. But basically, the scientist would drink the H. pylori to infect himself and then eradicate it to show. Because for the longest time, they were like, no, these ulcers aren't being caused by a microorganism. They're they're by stress, they're diet, etc. There's other things. And there was this one scientist that was convinced otherwise. But anyway, so now we're in an enlightened age. So now we know that H. pylori can be a culprit in causing ulcers. And so that is something you're going to have to treat some of your patients for. And if that is the case, you will have to use a multi-pronged approach. So there's a cocktail, I kept saying cocktail before, a drug cocktail. I do want you guys to know all these for testing purposes, so please put a star here of all the potential medications that can be used. And you'll notice that it's 2 or more of these plus a proton pump inhibitor. So we have an example there. So it's going to be a combination there. UpToDate has some great visual guides as usual. I love UpToDate. Thank you for UpToDate. But here is just the initial approach to antibiotic treatment for H. pylori infection. This is more for ICM, and don't stress about this for testing purposes for me. This is more FYI for my course, but this may be beneficial for your ICM. This one I do like, and this one could be beneficial for testing purposes or help you study for my course because it gives you the drugs here, which is what we're concerned with. Recommended first-line therapies for H. pylori infection. So put a star here. And the star is for, I want you to know of all the drugs and combinations that can be used. But I don't want you to memorize the dosing frequency and the regimen names. Rather, and like I said back here, put the star here. I want you to know of all the drugs that can be used. So you'll notice PPIs on here, clarithromycin's on here, amoxicillin or metronidazole. So just be able to pick out, so if I gave you a list, let's say, I want you to be able to know which drugs could be used. So, and then the other reason I gave this slide too is because I want you guys to know when you're out there prescribing, you can actually prescribe these regimens. They're commercially available products that they have, where they have this for certain drugs, and then how you dose them. It has it there. So hopefully that's clear. Students in the past have they seem like they have wanted this combination product thing, but then they start freaking out because for testing purposes, they're like, I'm gonna have to memorize all this. So yeah, so for testing purposes for my course, don't worry about this slide other than it's good information. I mean, and I think it'll help with ICM. Don't worry about this slide too much. Just here, the drugs column, just, make sure you know which drugs are there. And then here to, make sure you know all the different potential therapeutic regimens, and that, the PPI is always a part of that, the proton pump inhibitor. So hopefully that's clear. But if not, as always, just email me, because it seems like there'll be stuff that happens in the past and I'm like, I'm going to make it super clear this year. And then I try to make it super clear, and then there'll still be students, which is fine. It's great. And I love you guys, all your emails and everything. So yeah, just email me. But hopefully this year is a little bit more clear, or yeah, more clear cut than last year. But anyways, speaking of also too, last year they liked me to add this stuff. So the treatment regimens for H. pylori, again, this is good stuff for ICM. You don't have to worry about testing purposes for me on these slides. But again, I think it's good stuff. It's all from UpToDate. This isn't just stuff I made up or whatever. This is all from UpToDate. But again, based off feedback from students last year, they were like, could you just put something in here that was just kind of like a summary thing? So anyway, so that's why I added these slides and stuff. But so hopefully they'll help you guys and not hurt you guys. But again, for specific test purposes for me, don't stress too much about these slides. This is a slide I would stress out about for my test. No, we got put a star by here. As usual, I like these tables a lot. Make sure you notice it's a summary of all the drugs, clinical applications, put a star by that. Adverse effects, put a star by that. Contraindications, this is all stars all over. It feels like a Bootsy Collins concert. No, I'm joking. All right, he was before your time. No one listens to Bootsy Collins anymore, right? Except for my dad had a vinyl record I would listen to when I was a kid. But yeah, lots of stars all over. Yeah, this is definitely important for testing purposes. Antidiarrheal drugs. Okay, we're going to keep going here. Stop in probably the next section. But these basically, what do? They stop diarrhea. Cha-cha-cha. No, okay. Sorry, I have Tourette's with that. I can't say it. I can't say it without it. But first we have the opioids, which students a lot of times are surprised with. We will be talking about the opioids again ad nauseum during the musculoskeletal module, but we have to talk about them now because they are related to the GI module. Specifically, they help stop diarrhea, of all things. So opioids are super magical drugs, and unfortunately there is an opioid epidemic and people abuse them and everything, but these are a couple here that have GI applications. So yes, please know these for testing purposes. Again, I had students in the past say like, well, opioids, well, we're going to talk about in the musculoskeletal module, right? So don't need to worry about them. No, please worry about these. These are going to be on the test for the GI module. You notice too, there's a couple here. And let's see right here. Yeah, so the diphenolate with atropine and the loperamide. So the diphenolate in the US will always be with the atropine, and I'll get to that in a little bit. But so you can add that there if you want. And the brand name for that is Lamotil. It is a controlled substance, but it is a C5, I believe, C5 or C4. So it's a controlled substance, but as you guys are going to be able to prescribe it, so it's not a C2. And then loperamide is interesting because it's actually over the counter. This is in Imodium or Imodium AD. So yeah, and I had when I was a pharmacy student, there was a guy who came up, and we were super busy, and it was like crazy busy HEB, and I was running around and stuff, and I'm supposed to help out because I'm a pharmacy student, right? So I'm there, and then the customer wants to not talk to me because I'm a student. He wants to talk to the pharmacist. So pharmacist come over, so he's super busy, and then the guy had a bottle of Imodium AD with him, and he's like, yeah, I want to take this because I think it's going to be good for my diarrhea. And the pharmacist is like, yeah, AD, antidiarrheal. What do you think it's for? And I just remember thinking in my head, this guy is not very happy with us right now, because he looked at me and he's probably thinking I should have just talked to this pharmacy student who was, but anyways, yeah. So I'm not going to name names or anything. That pharmacist was super stressed out, super strung out, and not going to make any apologies. But so I always think of that Imodium AD, antidiarrheal. What do you think? No, but your patients aren't healthcare providers. And so that was an important lesson of, you don't just assume that everyone knows everything and that just because it's on a bottle and it's for diarrhea or whatever. But anyway, so I will forever remember Imodium AD, and that is burned into my brain because of that. They also are sometimes called as opioid antidiarrheals. You hear that, and that's technical, but you can also just refer to them as antidiarrheals. For my testing purposes, I do want you to know that they are opioid antidiarrheals, but just when you're out in practice and stuff, when you're referring to loperamide, for example, it's over the counter, you don't have to be like, that's an opioid antidiarrheal. You can, and it's technically correct, but usually people just say it's an antidiarrheal. So, or they'll just say it's Imodium, right? But anyways, these both are effective because they help slow down peristalsis. They decrease that motility, and they increase transit time, right? So all those things slow everything down, and they help stop, or rather lessen the diarrhea. So these can be one of the strategies or one of the tools you're using when you're trying to treat diarrhea. It is important to note that loperamide, it is an opioid, but it does not cross the blood-brain barrier. So therefore, it does not have the addiction potential. It doesn't have the, abuse potential, because people can't get euphoric. You can't chug a bottle of Imodium and be like, yeah, it's the weekend, I'm going to get, no, it doesn't work that way. You'll just won't poop for the weekend. I don't know, unless that's how you want to party. I mean, if that's how you want to get down, I don't know. But anyways, I'm not here to judge anybody. No, but so loperamide, it's over the counter opioid because you can't get high off of it, basically. Where the diphenolate, diphenolate does cross the blood-brain barriers up here, so theoretically you could get high off of it, and that's what people were doing, unfortunately. And then that's why I'm going back here. That's why they added atropine. So they have the atropine listed added to the diphenxylate because it does cross the blood-brain barrier, and you can get the euphoria, you can get the high. There is abuse potential. That is why it's a controlled substance, even though, I mean, it has the atropine with it. So I believe we've gone over the atropine before, but basically take-home point, and if we haven't, we'll cover it in the future. Take-home point with atropine is an anticholinergic medication, anticholinergic, antimuscarinic, so it has really nasty side effects. So bad side effects. So if a person were to ingest a high quantity of the diphenoxylate plus atropine, which is the like I said, it's a generic Lamotil, I don't know if they would. I'm not going to say they wouldn't get any of the opioid effects because it does cross the blood-brain barrier, but the atropine and the anticholinergic effects would be so intolerable that they probably wouldn't be using it. You know, that's why it's not a drug of abuse, really, is because it's, and I guess theoretically, and this is probably reason it's controlled, if you were like a master chemist, you could separate the diphenoxylate and the atropine, but I mean, master chemist, drug addict, who you could probably just go ahead and get another opioid on the street or from a prescription or something. I don't think it's really worth the trouble, is what I'm trying to say. But anyway, so yeah, it has diphenxylate, has the atropine with it because it does cross the blood-brain barrier. So remember that, and please put a star by that. I want you guys to know the difference between loperamide and diphenoxylate for testing purposes, right? One's over-the-counter opioid, one is not. And then the atropine, and one little thing with atropine that I think will help you. All right, my little favorite thing that I don't really like, but no, some people like these. The anticholinergic adverse effects. How does the hair dry as a bone, blind as a blood? So it's just basically take-home point. Please remember adverse anticholinergic side effects, bad deal, and you get those with the atropine. So that's why it's added to it. Let's get back into the presentation then. So hopefully that was clear. All right, so they're used for, again, acute non-specific diarrhea. They can also help with IBD or if a person has chronic diarrhea. But you definitely do not want to use these if a person has any kind of blockage or anything, or if they have UC, ulcerative colitis, because it actually can cause a toxic megacolon. So this contraindication there on that one. And so as far as its uses, over the counter, especially with the loperamide, it's not recommended to be used long term. And the idea is, and again, if they come to us in the pharmacy, we want to let them know if they're having diarrhea for, more than a day or so, they should be seeing a healthcare provider. So they should be going to see you guys because, luckily in the US and in developed countries, diarrhea isn't a killer like it used to be, but in developed countries, it's still a killer. And it can be a very serious condition. But in the US for our fragile population, so pediatric, geriatric, immunocompromised, or if the person has other issues going on, diarrhea can be an issue. So with the loperamide, it should be used, acutely is really kind of where it should be used. But anyways, but these can be prescribed chronically, and I have dispensed them for chronic use and stuff. But specifically the loperamide, because it's over the counter, that is something that you want to try to encourage your patients that they have diarrhea for more than a couple of days, a day or so, that they need to be seeing a healthcare provider. Some more antidiarrheal drugs. We have the locally acting ones. Again, we'll notice here we have the bismuth subsalicylate, which is the one we already talked about, but it also it's good, like I mentioned, with traveler's diarrhea. And mechanism of action here, just basically that these again kind of slow things down by being absorbent and help decreasing secretion. So again, sort of clogs things up. And then there's also the absorbance, so kalinpectin, which is kalinpectin here, and that can also be beneficial to, we'll talk about in the toxicology module, but that can actually help bind it to toxic substances. So here we have the summary table too. So again, pay attention to this. I like this. Put a star by here and make sure you guys note all of these. Prokinetic drugs. Okay, so we're about halfway through here, so we'll go ahead and stop here. This is slide 48. So we'll go ahead and stop at slide 48 right now. As usual, please email me if anything was unclear. If you have any questions, feedback, whatever, please go ahead and send me an email. And other than that, I'll talk to you guys later in part 2. All right, have a good one. Bye.